All right. Hello, everyone. Thank you for joining us for the health literacy training today. We are going to share my screen very quickly. And just give me one moment. All right, this is the Wayne County Health Catalyst for COVID Care. This is a health literacy training. Maya and I will introduce ourselves in just a few minutes, but this introduction is for the community health workers or other people that are joining on a video module or online. So what we ask is before you start the session, go ahead and pause right now in the video, and you can either scan the QR code here or the links are provided below. And go ahead and do the pre-session evaluation. We'll come back when we have our audience here for the day and continue on. So thanks again for joining us. I don't know how to stop the remote every time. Resume. Okay, so I guess we can start with some welcome and introductions. I'm Dr. Carolyn Custer, also known as Dr. C. I'm the project director of this part of the project, which is specifically building and preparing a health literacy training. And I'll turn it over to my lovely co-host.
Hi, thank you. My name is Maya Campbell, and I'm with Mishwa. I'm also a community health worker and a champion for our community. So I'm so very happy that everyone is able to join us today.
All right. So our agenda for today, we're going to do a pretty brief overview of health literacy, and then we'll talk specifically about 5 health literacy interventions to improve health literacy. We'll take a short break, maybe 5 minutes, not 10, go through some strategies specifically for vaccine hesitancy and COVID, and then end with a case discussion if we have time. The things that we'd like you to take away from this are being able to describe health literacy as a determinant of health, identify strategies like we just talked about, becoming familiar with culturally and linguistically appropriate services and standards, and understand the causes of and strategies for vaccine hesitancy specifically. So before we get started, I just want to say to Javon and Kim, this is meant to be an interactive learning module. So please feel free, Kim, to put questions or comments in the chat, or to even, Javon, if you want to go ahead and ask. Either way, we are welcome, your engagement. So let's get started. So I don't know if you've ever seen this picture before, but we'll have to start our discussion of health literacy with this discussion of equity, health equity. And so for a long time, this image has been used to show the differences between equality and equity. And as you can see with equality, everyone gets the same size box, right? But we notice that you can't give everyone the same box because people have different abilities, right? So then we talk about equity, which is giving everyone what they need to succeed. But we're going to take it one step further. So now we have this other image, which shows the concept of justice, right? So we're talking about not just equity, we're talking about removing the systemic inequity that was created in the first place, right? So removing the barriers and creating systems that are equitable. And that's what we're doing, right? So we'll go ahead and continue on. Most of us know about social determinants of health in some fashion, but these are the factors that impact health that aren't necessarily the clinical care you get in the office from the provider. And we know that clinical care is only a small percentage of what makes a healthy person. So all of these different things where people, live, work, and play, as we say, can impact your health. And so we see this a lot in our communities, and we have to make sure that we are aware of these things. And you can see even here, health literacy is part of it. Providing cultural and linguistic competent care is also part of it. So I'm going to turn it over to Maya.
Thank you so much. So what is health disparities? So the CDC defines health disparities as differences in the burden of disease, injury, violence, or opportunity to achieve optimal health that are experienced by socially disadvantaged populations. They exist because of health inequities and factors like social determinants of health, which we'll get into, and systems designed with structural racism. So health literacy in Wayne County. So systems are built with structural racism. As we know, or is anyone familiar with the term redlining?
Yes, familiar with redlining.
Okay, can you explain what your knowledge is of redlining, Javon, if you don't mind?
So it was the redlining was where minorities were allowed to live. So certain zip codes where white affluent neighborhoods, they didn't allow at the time African Americans or any minorities to purchase in those areas. So they quarantined to the district, which they literally used on a map at one time, used to draw with red lines where African Americans and minority people could stay.
And that's absolutely correct. And as you mentioned, within those boundaries, there was limited access to things like healthcare and education, which, as we know, does negatively affect that population. So unfortunately, Detroit does have a history of redlining. I'm sorry, we can go to the next slide. So what does health literacy mean? So when we hear that term, what does that mean? Does anyone want to share? Kim, do you want to share your thoughts? I know that you can't, you're having issues with audio. You can always put it in the chat as well.
I feel like it comes down to how we, as healthcare providers, are talking to our consumers. So that way we're not talking above them, but also not talking beneath them or at them, but trying to communicate across like evenly, like an even playing field. So that way they feel like they're heard and they're not talked at, but the care is directed with.
Absolutely. Absolutely. Thank you so much for that. So yes, that is definitely one component of it. So we'll get more into we'll dig deeper into the meaning of health literacy. Dr. Custer, do you want to go over Healthy People 2030?
Sure. So every 10 years, the United States, the CDC puts out the Healthy People report. And in 2010 and 2020, they had added personal health literacy. So improving health literacy of our consumers, right? So what is it? It's the degree that we have to find, use, and understand health information, right? But what Healthy People 2030 did was they added an additional component, which was a gap that it was missing, which is organizational health literacy. So Javon, just like you were saying, it's our ability, right, to equitably enable individuals to find this stuff, to use the information and inform their own, healthcare and empower their lives. So it's not just about improving consumer, it's about improving all throughout the org.
Yes, thank you. And I do just want to mention that Kim did put in the chat that her definition of health literacy is common knowledge of health issues, which is correct as well. Thank you for that, Kim.
Thank you.
All right, so we'll discuss some health literacy components. These are the skills and knowledge needed to interpret health information. And literacy is, of course, reading, writing, basic math, speech comprehension skills. Numeracy is the understanding of how math is used in the real world. And factors that impact health literacy, the complexity of the health information being communicated, the language, the age of the patient, state of the health, are they anxious, are they sick during the appointment, and also cultural background. So the way the information is communicated by the health provider is another factor of health literacy. All right, so this is just a graphic of the individual factors and the systemic factors that we just touched on.
Okay. All right, so we're going to go through some impacts of limited health literacy. So for individuals with lower health literacy or limited, they might be less likely to use preventive health services such as our screening test, right? Our pap smear, colonoscopy, mammogram, etc., vaccines. Less likely to effectively manage chronic disease. You need to know about the medical information to some extent, right, to be able to effectively manage yourself. More likely to have poor medication adherence, higher rates of hospitalization and use of ER, higher mortality rates, This one, we see a lot of reporting a sense of shame about their health literacy. We'll go into some red flags in a few slides to review this. And at the end of the day, this is all associated with higher healthcare costs and expenditures. So there's a lot of different impacts that having limited health literacy can lead to. And so this is why we're doing what we're doing, right? To learn how to better effectively communicate and transmit that information. On a community level, there are some impacts as well. For example, missed opportunities for services such as health fairs, vaccines, preventive screenings, lack of preparation for emergency or disaster, missed warnings regarding environmental safety, such as contaminated water, or even public health, food safety stuff. All right. So health literacy and literacy, which Maya just told us about, the average reading level of adults in the United States is 8th to 9th grade. However, the most health education materials are 10th grade level or higher. So there's an issue there, right? So what we recommend is that our reading level of materials is about the 5th to 6th grade. And this is a universal throughout the country recommendation. So that's why we have to really evaluate the materials, and we'll take a look at that in just a minute. Red flags, these are the things that could, that you should look for when you're with your consumer, and that could indicate that there's low health literacy. Things like frequently missing appointments, perhaps incomplete registration forms, non-compliance with medications, asking fewer questions. This is something that we'll talk about again. You know, the person who you're talking to at the appointment and they're just nodding, right? Or maybe not asking questions at all. This goes along with that sense of shame that we talked about earlier. It can be hard for people to admit that they might have a problem with reading, and that's why we need to take that upon us and make an environment where it's safe and comfortable for people to ask questions. So we talk about using a universal precautions approach. Who knows about, Javon, have you heard about bloodborne pathogens?
Like just coming in contact with blood in
Yep.
general? Yeah.
Yeah, right. So every time you work in healthcare, right, we learn about bloodborne pathogens. Because we don't know, and you can't tell by looking at a person if they have HIV or hepatitis, etc. So we have to assume that all blood is infected, and that's called a universal precautions. In the same way, you can't assume what a person's level of health literacy is by what they look like or what their education level is. It just doesn't translate. So the best practice is to assume that all patients have some difficulty understanding, and that way we can learn to communicate better in ways that anyone can understand. And that's what we're talking about. And the goals of doing this are really to simplify communication, like we've talked about, confirming comprehension, making the healthcare system easier to navigate, and to support our patients' efforts to improve their health. One side note, I just want to say, Maya and I work with patients because we're on the medical side of things, but we understand consumers, patients, members, clients. And again, the more we normalize, the less we stigmatize. So if we are empowered as a workforce to engage with universal precautions, it'll be just a better system overall. And here's a chart that shows that, we're not going to go through every spoke, but this is what a healthcare literate organization looks like. So it has to start from the top. Leadership has to prioritize health literacy. And then it kind of goes into every part of operations. So, you know, just something to consider as you work with your teams to create health literate environments, that these are some of the components. All right, I'm going to turn it over to Maya.
Thank you. So would anyone like to share a time when having low health literacy may have impacted you or a loved one? Javon or Kim?
I think well, my dad was diagnosed with diabetes at first. It took for me, I had to read background stuff when he was like, this was like years ago, but to understand what it was, because it wasn't explained, you know, for the most part, it was just called the sugars. So, and so you think like if you stay away from sweet stuff, then you know it goes away. But which is true-ish, but then you learn like, you know, increased activity, less sedentary, all these other things can also, besides just limiting sweet intake. And then like for him, he definitely thought switching from regular pop to diet pop was like the end all be all, and he was good to go. So yeah.
Absolutely. Thank you so much for sharing that, Javon. And I definitely can relate to that. I've had family members who had the sugars. So they didn't clearly understand it's not just the sugary things, you know, it's the starches and some of the fruits. So absolutely, that's a great point. And I do see that Kim put in the chat. My father would take off his nicotine patch to smoke because he was told not to smoke with the patch on. So yes. Thank you so much, Kim, for sharing that. There are lots of misinformation regarding health literacy, and it really does come down to lots of different factors that go into having a patient or a client understand, truly understand what's being communicated to them. So thank you so much. And Dr. Custer, did you have anything to add?
I don't think so. Just that, you know, again, when you're working with your consumer, you just never know. So it's important to always approach it that way.
Yes, thank you.
Yeah. Okay, so we're going to turn over to some interventions. Maya.
Okay. Some health literacy interventions we're about to go over. These are evidence-based interventions and strategies that are used to increase the patient's health literacy levels, and they do create a more health literate environment. All right. So the first strategy is clear communication. So greeting the patient when they come into the office, making eye contact, listening carefully, excuse me, slowing down, using the patient's words is a very powerful tool. It lets the patient know that you're actually listening to them, and those are words that they're using and that they typically understand. Limit the content and repeat the information that's relevant. Graphics. Graphics are an amazing tool and demonstrate how these things are done. I do often think of the practitioners that I work with that would demonstrate how to use blood pressure cuffs, and that was very powerful. Invite patient participation and also encourage the patient to ask questions. One that I skipped here, I'm sorry, is use plain non-medical language. That's very powerful as well. Okay. Okay, so 7 things to consider when communicating about health. Trust. Will the person or does the person trust you? So lots of times the trust does come in from the community health worker because we are the smiling face, or we're the person that the patient typically communicates most with. So sometimes the use of a community health worker to communicate information. So the second point is information. Is the information necessary? Is it too much? Information overload is definitely a thing. So considering if that information is relevant to the appointment. Motivation. So what's relevant to the person's personal motivation? What goals do they have? We'll get into motivation and motivational interviewing later in the presentation. I'm sorry, I always take this slide over, Dr. Custard. I think we're supposed to split it in half, or would you like me to continue?
Go ahead and finish the slide, Maya. That'd be fine.
Okay, so the environment, that's the fourth factor. What are the conditions that surround and affect the audience? The capacity, what is the person's ability to act on the information? Do they have barriers? We'll get into that a little bit later as well. But it's difficult for a person to discuss certain things if they have other barriers that are preventing their basic needs. What is the patient's perception? That's point number 6. What will the audience think about the information, and what will inspire them to act on that? And the response, how will the person respond? How did the person respond, and what can they do to stay engaged and have them support and take action? So thank you so much.
All right, thanks, Maya. All right, so using plain language, we just touched on this a little bit, but again, we want to use plain language instead of using medical jargon, right? We don't want to confuse people. And so these are just some of the examples. One that I always highlight is diet. So if you ask a consumer, what is your diet, right? They potentially could think, okay, Weight Watchers, Atkins, right? Paleo, there's a lot of different diets out there. But in reality, what we're asking is, what do you eat? Right. So being clear about what you're asking. Another example is the word adverse. That can be tricky. Using the word bad is a better example. And I see we have Marcel that just joined. If you are joining us for the health literacy training, welcome.
Thank you very much. I'm sorry, I'm having connectivity issues right now.
No problem. No problem. Okay, so your COVID test is positive. So I bring this out because this was an example that we had. We were doing a screening, right? A mass screening, and someone tested positive, and they thought that was a good thing because positive means a good thing. And that's true, it does. But in this case, it meant they had COVID. So we actually started writing out, you have COVID or you do not have COVID. And that's okay. We switched our language around to match, our audience. So just be wary of terminology and jargon. Okay, so health literacy strategy number 2 is effective health education materials. Does anyone have questions about communication? Okay, go ahead, Javon.
I was just saying no.
Okay. So our next strategy is using effective materials. So let's go through a few and then we'll have some fun. So again, materials are effective when they're easy to read and understand. And as a reminder, check the readability and aim for the 5th to 6th grade level. The purpose of the material is clear. We want clear messaging. We don't want to confuse people, especially about things like COVID or public health measures. Common everyday language, like we just talked about, material is broken up into chunks. People get wary, right, when you see all these words. So breaking it up with chunks or pictures is a good idea, the material. Identifying at least one action item and using visual aids. And then the last thing is beware of confusing numbers. Sometimes, especially like relative statistics can be confusing. So now what we're going to do, Javon and Kim, is we're going to take a look at some materials and we're going to ask you to evaluate. So the first slide here, and hopefully you're not on a phone, this will be very tiny. The first slide here, these are 3 different COVID vaccine flyers meant for children and school-age children. So this one was MDHHS, this one is CDC, and this one is Authority Health, which was my previous employer. So looking at these 3, which one has the clearest message to you? Or what do you think about them?
The middle one. It has less writing and it's just straightforward to the point.
Right. Like, keep your cubs safe. People see this and they think, oh yeah, we want to keep our kids safe. This one, keep the school year fun going. What does that mean, really? And this one's, again, small words. It's a cute picture and everything, but it doesn't really necessarily have a clear message, right?
Yeah. And Kim did mention in the chat that she agrees that the second one does have the easiest to read messaging.
Okay, great. And you can also see, there's an action call. It's clear. All right, let's go on to another one. So this one was released by MDHHS, and this is the worst one. I have a problem with this one every time. So thinking about the people that you serve, would this be effective? It says, decades of research followed by, months of clinical development. And it talks about science and doctors and all this. Would this work for what would your patient population think about this particular flyer? Would this work?
I don't think so. No, I don't like it personally.
Yeah, Kim said it's too wordy. I'm sorry,
Yeah.
Javon.
No, exactly. That's what I was thinking too, Kim.
Yeah, and the main message is science have taken hundreds of steps to open this door, which leads to people reading that, it's not very clear. Okay, so the next three are in a series here. They're all from MDHHS, and these are some examples of messaging that maybe isn't so clear and why. So the Omicron booster, when they came out, and also in this, do you have COVID? We'll start with this one. You can see that there's multiple asterisks in this message. And I don't have a problem with asterisks, but for the general public, when you start having multiple conditions that you have to read below, that can be a turnoff. Does that make sense? Yeah. And then this one, I still get calls about this one. Remember, if you're symptomatic, how long do you have to stay home? In day 1 through day 5, the whole thing that was confusing was, can you leave your house? It says no symptoms or symptoms have improved, right? So people are saying, well, what does that mean? I even had girlfriends that said, my daughter's employer wants her to come back on day 6, but she's still coughing a whole bunch. What do I do? And, so it was confusing to everyone. And again, this is, with the asterisks, double asterisks, just examples of how messages can get muddied. And the last one, make a COVID-19 plan. There's 4 really good points on this flyer. What do you think about all the extra information? Does anyone have any thoughts on this one?
I feel like y'all go ahead. What did Kim say? She probably was what I said too.
She said, Kim said in the chat, I'm sorry, Giovanna, she's said that it's too much. It is too wordy.
Yeah, I think if you just left with the bold parts, you'll be fine. It's everything else is kind of like, okay.
Yeah, exactly. I mean, information overload, right? Okay, so now I'm going to turn it over to Maya to compare 2 more.
Yeah, so thank you so much for that. So these next flyers, well, this first flyer is from MDHHS. So when you see this flyer, and we're considering the population in which we serve, so what do we think about this flyer? If you were a parent sitting in a pediatrician's office or health department, and this was the flyer, off the bat, what is your initial feelings about this flyer? There's a lot going on here. It's a little bit scary to me. Just my initial feelings. There's a little baby crying. There's someone in a hospital bed. So it's a little emotional or emotion evoking, and there's a lot of words. Yes, Kim mentioned in the chat there's a lot of medical jargon. So this flyer is just, there's good information here, don't get me wrong. I love the bullet points. But there's a lot of information, and some of the pictures make it very scary. Okay. So how do we feel about this flyer? So this flyer is from the CDC. So it talks about vaccines, children and teens. There's a lot of messaging here as well. But how do we feel about this flyer? Our initial thoughts, same scenario, if we're considering the population served, and I'm a parent or a guardian sitting in a doctor's office, how would we feel about this flyer?
It's too crowded. Too much.
Yes, it's a lot. Yeah.
Hard to read.
Yes, it is hard to read. But both the flyers, the last 2, and Kim said I stopped reading after the first sentence. Yes, there's a lot of information on that second flyer. Great information, don't get me wrong, but lots of information. And as we mentioned, information overload, it's a real thing, and it does, like Kim mentioned, it makes us shut down, and we'll stop reading after a sentence or 2. So the last 2 flyers, the one from the MDHHS and this one from the CDC, it's the exact same information. So the second one's super cute with the cartoon kids, and the first one is a little scary with the pictures of the kid crying and the person in the hospital bed, but it's the same information. Okay.
Yeah, this could definitely be simpler. All right.
Okay. I think this is my slide. So
Yes.
I'm using health materials. So when using health materials, just like we talked about that universal precaution is the same approach. Don't assume that your patients can read the material. When reviewing a handout, it's important to circle or highlight those important points. Because as a community health worker, we don't always get to choose the material that we're given. And like we mentioned in the last two slides, there was very important material on or very important information on that material. Sometimes circling or highlighting is the best option. Personalize the material by adding the patient's name or writing the medication. Use a teach back method, which we'll learn a little bit later, to confirm the patient's understanding, and emphasize the importance of keeping the material so they can refer back or follow up with the patient on that material. So make sure the person also, or the patient or client, has access to the internet when we're recommending digital materials. Sometimes when we get in our groove, it's easy to refer to a website or to online resources, but we have to make sure that the patient has access to those online resources. Thank you.
All right. Oh, I
Oh,
forgot.
I'm sorry. One last point. Obtain the patient's feedback on the material. So getting their feedback and asking them how they feel on the material does help to improve future materials.
All right. All right. So before we go into our next strategy, does anyone have any questions or comments about using effective materials? Okay. So just as Maya had just mentioned, our next strategy that we're going to discuss is teach back. One of the things that we know are, especially when you're at the doctor's office, you're already stressed at some level, right? So it's easy to forget. But studies have shown 40 to 80% of medical information is forgotten, and nearly half of what's remembered is incorrect. So what we can do is use this strategy called teach back to help our patients, to help ensure that our patients have understood what we've told them. Has anyone learned about teach back in the past? Okay. So there's a couple things we'll go through today. Teach back is one of them. Motivational interviewing is another, that you could literally have a whole lecture series about individually, right? So we're going to go through an example of teach back, but I encourage everyone to either follow up on YouTube. There's so many videos of this in action, or follow up with your team at your organization to discuss. So what is teach back? It is exactly what it sounds like. It's a way of checking understanding by asking patients or consumers to explain in their own words what you just told them to do for their health. So it's really not a way, it's not pimping or questioning patients, right? We don't want them to feel offended. This is a way of ensuring that we do our job correctly. And that's the emphasis that we need to put when we're doing teach back. It has been shown to improve patient understanding and adherence, decrease callbacks, canceled appointments, and improve patient satisfaction and outcomes. So this is a really good technique this is something that you just get in the habit of and just start using as a tool to have in your toolbox. So some of the elements, again, empathy is always important, using a caring tone of voice attitude, appropriate eye contact, comfortable body language, again, the plain language, right? We talk about that all the time, and using materials to support it. And what we'll do is we present the material, then ask the patient to explain back in their own words. And you want to document. Now here's a little graphic to show how do you use teach back. So you want to chunk the information. You don't want to go through, if the patient has 3 different diagnoses, let's say they're asthmatic, diabetic, and blood pressure, and they have 3 different things to talk about or to remember to do, you want to chunk each part individually. And then you just present the material and ask the patient to teach back. So now that I've told you, tell me, how are you going to do this, right? And using materials is important. If the patient doesn't understand, then you just teach back, and you can use a different way. You can maybe use a different handout if needed. And then you just keep doing this until the patient verbalizes understanding or can tell you what the plan of action is. So what we're going to do is an example. And like I said, please feel free to seek out more examples. So in this example, I'll be the healthcare provider and Maya will be the patient. We're going to use slides, but just imagine that what's on the slide is actually in a handout form and that I'm using it with Maya. Okay, so Mrs. Campbell, as you know, your COPD and diabetes put you at higher risk for developing severe COVID-19. I'm going to prescribe you the antiviral medication for COVID called Paxlovid. Paxlovid consists, Paxlovid is, this is what a dose looks like. There's 2 pink pills and 1 white pill in each packet. And you'll need to take the whole packet twice a day for 5 days. So you take all 3 pills twice a day for 5 days. These are the actual medication names. Here's some additional information about taking Paxlovid. I've highlighted the most important instructions, such as taking the tablets whole. And here's a list of medications that you cannot take with Paxlovid. Are you currently taking any of these medications?
Yes, I do take St. John's wort.
Okay, so we need to make sure that you don't take that while you're taking the Paxlovid. All right, here's some side effects to look out for. The most important thing is liver damage. Please call us if you experience any of these symptoms: yellow skin, itching, dark colored urine. And here are some other side effects. I've circled them. They're the most common. You can expect these to happen and resolve within a few days. So I'd like to make sure I explained everything clearly to you. Can you please tell me how you're going to take Paxlovid and what you need to look out for?
Yeah, okay. So I take each pill packet, or each pill packet has 3 pills. I take 1 packet 2 times a day for 5 days. Avoid taking my St. John wort while I'm on the Paxlovid. And I can't remember what side effects to look out for, doctor.
Remember, liver damage is the big thing.
Okay, yeah, that's right. So I'll give you a call if I notice any changes to my skin, or if my eyes turn yellow, or if my skin gets really itchy, or if my urine gets dark. I'll be sure to give you a call.
Great, I'll see you in 2 weeks. Okay, any questions? It was a pretty basic example, but using materials is important. Okay, so we'll go ahead and move on. So health literacy strategy number 4 is not necessarily an evidence-based intervention. It is something that we've done. I did with my residents in the past, so I just wanted to quickly go through it. Prior to the pandemic, we were doing health literacy in a laundromat at 7 Mile and Van Dyke, and we were going every weekend for 2 hours, and the resident doctors would present on a health education topic, and we would meet every week and do a quality cycle and figure out what worked and how people responded. And it was going really well, and it was exciting because we were engaging and empowering people about their health. Unfortunately, that project did go under since the pandemic occurred, but we, in response, were able to come up with a new project, which was the Small Steps to Health, which is the whole point of this. So Small Steps to Health was a project done with a couple different partners. And really the whole point of it is small step behavior change. So, we all have, I apologize. Let me take that. Maya, we're going to have to do some editing of this one for sure. Just kidding. So during this project, we had 5 different topics. We had diabetes, high blood pressure, stress management, nutrition, and physical activity. And those are very common to a lot of the population that we serve. And the whole point was, rather than, prescribing something that was unattainable, working with the patients to figure out a small step that they could take. So for example, rather than saying, you need to exercise 150 minutes a week per the, cardiac recommendations, it might look more something like, so how can you increase activity? Are you able to do some YouTube videos with your grandkids, in the kitchen? Can you do some dance videos? A lot of people do those things, right? So that is a small step. That's something attainable. The same thing with, increasing water in your diet. Oh, you need to increase your water 6 to 8 glasses a day. A better way maybe would be, could you drink a glass of water every morning before you brush your teeth or before you drink your coffee? That's something small and attainable. So the whole point of this is really working to set small goals. Maya, do you have any other feedback, or does anyone else have feedback on setting small goals?
Yep, I noticed in the chat, Jaban said it reminds him of harm reduction goals. Yes.
Yeah, exactly.
And I know something small, a small behavioral change that I shared in a training in the past. I went through a weight loss journey, and exercise is not my favorite thing to do. The gym is absolutely not my favorite place to go. But as we know, that exercise is necessary. So one small behavioral change, instead of sitting down watching my favorite TV shows 1 hour a night, I'd stand, and Law and Order is my absolute favorite television show. It's a 60-minute show. So I'd walk in place for those 60 minutes. So, over the course of a week, that's, 7 hours of working out, walking in place. So that's what worked for me. So as Dr. Custer mentioned, it is really listening to the patient, finding out what their motivation is, and tapping into that and seeing what small goals that they can make, small obtainable goals that they can make. So thank you.
Okay. All right, so we'll turn it back over to Maya.
Thank you. So health literacy strategy number 5 is considering the language and culture. So fortunately for us in Wayne County, it is a huge mixing pot or melting pot of different languages and cultural beliefs. Here on this slide, I think it's a good illustration of some of the cultures that we have here in Wayne County. Dearborn, of course, houses the largest population of Arab Americans. So that's a beautiful thing. But with that being said, it's important to know our population served. So we'll review CLASS, which is CLASS. The CLASS standard means culturally and linguistically appropriate services. And CLASS is a framework to deliver healthcare services in a respectful, responsive way to the patient's culture and health beliefs, and prefaces to their communication needs. And the CLASS standard does promote health equity and reduces those health disparities. All right, so the CLASS themes. I'm sorry, I feel like I always take over at this part. Is this still my slide? Okay. So principal standard, it's also the governance of leadership and the workforce, communication and language, engagement, continuous improvement, and accountability. Okay, so some strategies to implementing CLASS. Access language preferences and language assistance needs. Use acceptable language assistance services. We'll get into that in the next few slides. Plan for interpreter services in advance. I know for me as a CHW, this was very powerful. One thing that I would do, I'd peek into the schedule for the upcoming days and look at what patients we had coming in and plan accordingly. Provide written materials in the patient's preferred languages. And some culturally related strategies. Respectfully ask the patient about their health and custom beliefs. Please don't assume. Avoid stereotyping based on their religious or cultural backgrounds, and acknowledge and address our own implicit bias. Okay. So some language translation services do's and don'ts. We do want to use bilingual clinicians or staff members whose proficiency has been confirmed, or staff who's trained as interpreter. We can use on-site medical interpreters or telephone or video medical interpreter services. I know that was a big one. As my time as a CHW, we would use the interpreter line, which was great. We do not want to use clinicians or staff whose language or medical interpreter services or skills have not been confirmed. Excuse me. This is the big one as well. We do not want to use the patient's family members or friends. I know this is a big thing. Lots of patients who English may not be their first language, they do typically have a family member or friend that goes with them to appointments to kind of translate. But this does pose a problem with the patient's privacy. And we want to respect the choices and have quality interpreters present. And minors should never be used as interpreters. Thank you. All right, I'll hand it back over to Dr. Custer.
Okay, so there's a website here at the bottom and care guides. And so University of Michigan has a department where their whole purpose is to create health materials in plain language. So you can look at this if you'd like. They have materials on every single different condition, I think, possible, and also in all of these languages. So go ahead and take a look if you need additional materials. Some of them are just, they're just black and white handout, like words. They might not be the best handout, like aesthetically, but the information they have is great for patients. So I encourage you all to go ahead and check out that website. In addition, we're kind of coming towards the end of the pandemic, but MDHHS also developed several COVID vaccine flyers in different languages. So I encourage you to look at those if you need any of those resources. Okay, so we're going to talk about cultural competence for a little bit. Go ahead, Javon.
Going back to those flyers before, those ones look better than the ones they made in English. Like they look like they were very straight to the point.
Yes, that is true. And they are actually really good flyers. Okay. So like Maya said, we are fortunate to be in Wayne County where we do have a mix of different populations. So cultural competence is really understanding this point. Religion, culture, beliefs, and ethnic customs can influence how patients understand health and how they take care of their health and how they make decisions related to their health. So cultural competence relies on the principles of trust, respect for diversity, equity, fairness, and social justice. So this is all the things that we've been talking about throughout this lecture. By considering culture, we can make better patient engagement. We can understand more and create treatment plans that are consistent with patient values. We talk about patient-centered treatment plans or family-centered treatment plans, and we need to consider culture. So these are just some examples of how culture can impact health engagement. Some of these you may be familiar with. Health beliefs. So for example, in some cultures, people believe that talking about an outcome will potentially cause that outcome to occur. So they would prefer to avoid talking about certain things. Some culture family members play a large role in healthcare decision-making. Elders, for example. Ethnic customs, roles of women and men in society may determine who makes the decisions about different medical treatments. Some religious faiths or spiritual beliefs may affect how someone uses the healthcare system or willingness to, accept specific treatments or behavior changes. Dietary customs, like we talked about, what is your diet? If we are prescribing patients to eat healthy fruits and vegetables, it's important to understand their own dietary customs. If they come from a different cultural or ethnic background, they may not have familiarity with the food that you're prescribing. In interpersonal customs, like we mentioned before, eye contact or physical touch may or may not be appropriate. So it's really important to understand the community you're serving and what is appropriate. There's even showing the bottom of your shoe can be very offensive to certain cultures. So just to know your population that you're serving. Like I said before with Teach Back Method, this is another part of this series where we could spend a whole semester talking about some of this stuff. So we're going to go through just some key concepts or ideas to consider when we're talking about providing culturally competent care. So implicit bias, we all have, we were all raised differently. We have different groups that we come from. We have different worldviews, and that creates bias. And it can serve as, it used to serve as a human defense mechanism when we were hunting and gathering, and staying with your tribe kept you alive, and people that look different, were the enemy, right? So it's our job to understand how we were brought up, what we understand about the world, and if we have any biases towards other populations or other people, and address those. And this is something that we're all working on, as a nation, and hopefully you'll have more training on this in your own organization. Has anyone on the call ever seen this book, The Body Keeps the Score? Ever read it?
Yes.
Yes.
I've only gotten through about chapter 5. It's really intense.
Oh, yes. Yes, Margaret, it's very intense. I encourage everyone to read it. Has anyone heard about or learned about toxic stress? Or adverse childhood experiences?
Adverse childhood experiences. Yeah.
Yeah. So, we now understand how trauma and toxic stress impacts the body, both physically and mentally and emotionally. And so I encourage you to learn more about this topic. Reading this book is a good way to start, although it is very intense. There's a lot of material, but it can be helpful. And so, a lot of times with the patients that we serve, they've been through trauma and they've been through toxic stress. And so we have to consider that. All right, so Maslow's hierarchy of needs, again, another topic that we could spend a whole semester on. Maya, do you want to go ahead and share some perspective on this?
Certainly. So I'm pretty sure everyone's very familiar with the hierarchy of needs. How this relates as a community health worker, just from my experience, especially during the pandemic, we had lots of patients who were going through lots of issues with mental health. So it's difficult to speak with a patient regarding getting into support groups or getting back into the groove of being around their friends and family when their basic needs or that bottom level of the pyramid, their food, shelter, was not met. So it's great to encourage patients to go to counseling and therapy, but it's difficult to talk to them about that when they're going through an eviction. So that just puts things in perspective. When that bottom level is not met, it's difficult to talk about self-esteem if I don't know how I'm feeding my children tonight.
Thank you, Maya.
Mm-hmm.
Yes, we always need to address these needs. Along with adverse childhood experiences, this is the pair of ACEs. This model comes from George Washington University, Dr. Dietz. And we know we are aware of all of this, right? But in order to restore our community and reduce and prevent adverse childhood experiences, it's really important that we address the adverse community environments that set up for these to occur, right? So just another reminder of all the social justice work that we're doing and we will continue to do to create more equitable and good environment for the community. And then the last part of this, we'll just close out and then we'll take a quick break. I give a lecture to some health professionals and who are in, like medical school, nursing school, etc. And we do a trauma-informed care lecture. And so these are some of the questions that I ask them to ask themselves, and I'm going to ask you as well, in creating a trauma-informed space. So you can put culture in here too. Have you considered the trauma this person sitting before you has experienced, or have you considered their language, their cultural beliefs, etc.? Are you creating a safe place for people to share, to share? Do you have any unconscious or conscious bias to consider, and can you even be unbiased? How does your background, history, etc., impact your ability to serve the person? Are your actions making others uncomfortable? Are the words you're using respectful and culturally appropriate? And are you actively listening, or are you listening to talk, or are you just talking, right? So along with trauma, culture, all of that, these are things that we need to consider to make sure that we're providing the best care that we can, that we're listening to our patients, and that we're creating safe environment. So on that note, that's a lot of heavy stuff. We will take a break. What time is it? It's 2:05. Does anyone have any feedback before we go to break on the cultural competence piece?
It's very relevant, so I like it. And I think one of my professors prefers the term aspiring cultural competence, so that way you realize that you'll never become culturally competent, but you're continuing to learn and be open to learning.
Mm-hmm.
Oh, I love that term. I hope you don't mind if I borrow that.
I'm going to.
Absolutely.
Okay. Awesome. Any other comments? Okay, so thank you for back to the break. It's just that kind of day. So now we're going to move on to some COVID-19 vaccine hesitancy strategies specifically. So we'll start with an overview. What is vaccine hesitancy? It's a delay in accepting or refusing vaccines despite having them available. And it really is one of the top threats to global health. And there are a few effective strategies to address this growing problem. So causes of vaccine hesitancy. This is what we've been talking about this whole time. A lot of these. So healthcare and socioeconomic inequalities and equities, right? Mistrust of the healthcare system. Lack of effective public health messaging or confusing messaging, like we talked about. A history of unethical research involving ethnic minority groups. We know that, that there were times in the past where minority groups were treated very unfairly with unethical research. So that's one of the reasons. Social disadvantages, like we talked about, lower levels of education, access to information. A huge problem now, the growing spread of misinformation, disinformation, and conspiracy theories. And barriers to access, not so much in Detroit, right? We have plenty of vaccine, but in other areas. So a quick review, we all remember this, but just as a quick review, the primary series of vaccination was a monovalent, meaning one strain, right? It only covered that original strain that infected everyone, and still is recommended for everyone ages 6 months and older. The Moderna, the bivalent booster came out, and this is 2 strains, right? So bivalent, it covers Omicron, and it does have some protection against the newest Omicron subvariants, which is fortunate. And it is recommended for everyone ages 6 months and older. So this field guide actually is very helpful. I have a list of resources at the end of this presentation that you can access this guide. There's 12 strategies that they reviewed, but the 2 that we'll talk about is motivational interviewing and combating misinformation. So let's go ahead and get started with motivational interviewing.
Great. So motivational interviewing is the guiding style of communication that balances good listening with giving advice. So it's designed to increase the patient motivation and likelihood of health behavioral uptake. It's based on respectful and curious ways of being with people that facilitates a natural process of change and respects the patient's autonomy. Okay, so the spirit of motivational interviewing. So this chart just gives some of the motivational interviewing and some of the old authoritative therapeutic styles. So in motivational interviewing, it's a partnership between the patient and the practitioner, and where joint decision making is made. Previously, or the old way of thinking is confrontation or confrontational. The practitioner assumes that the patient has impaired perspective and consequently imposes the need for insight. So I like to sum this up and say the patient is the expert on their situation, while the practitioner, of course, is the expert on the medical side. We can't disregard the patient's knowledge of their own circumstances, if that makes sense. Okay. So the next part is ORS. So when this acronym is broken down, it starts with open-ended questions. So asking inviting questions. And the examples are explain or tell me more about those sorts of, rather than are, do, and did, could questions, if that makes sense. Sorry, I feel like I rushed you that point. Please stop me if anyone has any questions. And affirmations, recognizing and reinforce the success of the patient. Be sincere. So whenever we're not sincere, it definitely comes across. And also motivational statements like, it takes a lot of strength to, sometimes I don't think our patients always understand how resilient they can be. So pointing that out does help build the confidence and also the rapport with the patient. Thank you. So the R is for reflections. So mirror what the patient or the client is saying. So it shows that you're understanding what they're saying, and it also shows that you're listening. So an example of this would be statements like, it sounds like, or it seems that. Those are good buzzwords. And the last part is summarize. By repeating what the patient says or giving a summary, it lets the patient know that you're listening, and it pulls together all the relevant information that the patient explained to you. And it also enables the patient or the client to clarify any information that was poorly communicated. So I know that was I'm sorry, go ahead.
No, go ahead, Maya.
Are there any questions about ORS?
That's where I was going, actually.
Okay.
So ORS is one of the more common models to apply motivational interviewing. But again, like we said, this has to be practiced, right? This is not a instant understanding. And we encourage you to continue to practice and look for more examples.
Absolutely. Thank you so much. So some motivational interviewing strategies to discuss COVID. The first one, again, start with open-ended questions and do not assume their acceptance of the vaccine. So start with a soft rollout to a controversial topic and acknowledge the patient's concerns without being judgmental. So empathy reduces the perception that you approve or disapprove. So really listen for understanding. Avoid criticizing the patient's information source. Because as we discussed in a previous slide, some of the sources may have come from very respected members of that specific community, like an elder, a church leader, and we don't want to criticize those sources because that may break the communication down and break the rapport as well. So instead of arguing, just give high quality factual information. Thank you. So show awareness of your status as a messenger, especially within communities of color. Who you are as a messenger matters, and your awareness contributes to authenticity and trustworthiness. Use examples of other messengers who resemble your patients. So link vaccine acceptance to a patient's hopes and goals. Every time we get to this part, I think of a patient. She was very hesitant about the vaccine, but she was like so super into being like super grandmother and being there for her grandchildren. So I learned that by listening. So, just speaking with the patient saying, hey, I know it's really important that you're there for your grandchildren. So, consider your grandchildren when you're thinking about the vaccine, how that will stop you from getting sick, and you'll continue to have that relationship that you want with your grandbabies. Thank you for that. Let's review an example.
Okay, so we'll do another reenactment. This time I'll be the healthcare provider and Maya will be the mother. This is a pediatric visit for vaccines. We're going to do the first reenactment using a traditional approach, which is where the provider talks down to the patient with an authoritative paternalistic style. And then the second example we'll do is the motivational interviewing, so you guys can see the difference between the two. Okay, so let's start with the traditional approach. Ms. Campbell, it's important to immunize your child. If not, you're putting him in danger. Do you know there's still cases of measles? This disease could be very dangerous. And what about meningitis? It could be fatal, You should update your child's vaccines as he is already late according to the schedule. We could do it now if you want.
Yeah, well, I don't see the urgency, and autism is way worse than measles. There are more problems and solutions with this vaccine. Moreover, it's completely unbelievable to give so many vaccines to a child all at the same time.
Studies have demonstrated that there is no link between autism and measles vaccine. The vaccine is safe, I assure you. You should be aware of the information you can find on the internet. Giving several vaccines at the same time is safe and not associated with more pain. We should do it now.
Well, I've heard something else, and not just from the internet. I do read a lot, and vaccines are not mandatory, so I can ultimately do what I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of diseases are much higher than the risk of vaccines. If I'm taking this time to speak with you, it's because it's very important.
Yeah, that's really easy for you to say. Everything is quick. But what if he gets autism? I'm worried about the risk of vaccines, but you don't seem to be worried about the overall health of my child.
Of course I am, and I'm worried about the fact he could get diseases that can be prevented by vaccines.
Yeah, I don't think we're understanding each other right now, so let's just talk about this at another time.
Okay, so you can tell I adopted the role of an expert and used a directive intervention approach based on argumentation and writing reflex. Very fancy words to say that I assumed the patient didn't know what they were talking about, so I talked down. And this type of intervention led to an opposition. So we're going to do this again, and this time we'll use a motivational interviewing approach. All right. So what do you think about the advantages of vaccination, Ms. Campbell?
Well, I know the vaccines protect children against several diseases that we don't see anymore. My child received all his first vaccines, but I'm a little worried about the measles vaccine specifically, as it could cause autism. For other vaccines, I have fewer doubts, but for that specific one, I'm very hesitant.
As you said, vaccines have reduced diseases in such an important way that they are now much less frequent. It's why you vaccinated your child when he was a baby. If I understand you correctly, with the exceptions of the measles vaccine, other vaccines seem safe to you?
Yes, I know it's a good thing to prevent those infections, but about measles, I'm conflicted. I've read a lot of books and articles, and lots of people are worried about the link between the measles vaccine and autism.
So you find it's important to protect your child against disease when the vaccines are safe, but you're worried about what you've heard regarding autism and measles. I see you've done a lot of research about the subject. If you agree, I could give you some additional information on the studies related to autism and measles.
Sure, that'd be great. I want to know exactly what's happening.
In fact, you're right. One study did hypothesize a link between measles and autism, but the study was fake and the author lost his medical license. More than 500 additional studies around the world have demonstrated there's no link between the vaccine and autism. The frequency of autism is the same in vaccinated children as it is in non-vaccinated children. What do you think?
Well, so I'm not so crazy to be worried about this?
Of course not. You're totally right.
Okay, well, thank you for taking the time to understand my concerns, and I think it's a bit clearer now.
So in this example, you can see that motivational interviewing allowed the mother in a non-judgmental way to express her concerns and her ambivalence, and we were able to give her solicited information that could be accepted in a better outcome. So that's our motivational interviewing. Again, the technique itself is something that you need to learn and practice. And any questions or comments? Okay.
Marcel mentioned in the chat that was a great example. Thank you so much for that, Marcel.
Thank you. Okay, so our last strategy is combating mis or disinformation. Does anyone know the difference between misinformation and disinformation?
I would guess that misinformation is inaccurate and disinformation dismisses the true stuff.
That's a great way to think about it, actually. Yeah. So misinformation is inaccurate and shared by, without the intention of spreading, fake, I almost said fake news, but false information. Disinformation is intentional. It's sharing information that's not correct for an agenda, right? And we know that we have both happening a lot. So let's talk about the role of social media and then the importance of trusted messengers, which Maya's already touched on. So this is our social media landscape. The whole point of this slide is how many different places you can get your information from. There's so many different sources, and depending on your age group and your connectivity, etc., it's just a lot of different places. So we need to keep this in mind. Some strategies. I think we just discussed this a little bit with COVID, but dissemination of factual and easy to understand information combats the mis and disinformation. It's better to provide facts than to argue, right? We don't want to judge or come off as judging. We just need to use credible sources to demonstrate facts. Now, the thing that people have said when we discuss this is, what do you do when your medical or the population you're serving doesn't believe your sources are credible anymore? For example, there are people that think the CDC is infiltrated, for example, or lying. So we have to deal with that as well. And trusted messengers, like Maya said, there's celebrities, faith-based, neighborhood champions, and all of you as healthcare workers in community health. So I just wanted to pull a little bit of data. This came out in November, I believe. And this might still work for some people that are vaccine hesitant. It is still true that there's a much less likely chance of being hospitalized if you had the vaccine, 29 times higher in unvaccinated adults. And then when we look at the death rate, we can also see that, and it's still true, even though it's becoming less of a virulent virus, people that have been vaccinated, and this green line here is the people who have received the bivalent booster, are not dying from COVID. So these are our up-to-date information that can be shared as far as credible information.
Right. So thank you for that, Dr. Custard. So this part is an interactive part. So can anyone share a situation where someone, either a patient or a family member or friend, refused to get vaccinated because of mis or disinformation? What was your reaction, and was it effective?
I think we, as a family, we talked about it for a while, and it was during the height of everything. So we had one faction of my family that was like absolutely not to vaccination, and the other side was like yes. But I think somewhere in the middle, everybody was like, given everything that they were talking about, and I think it was definitely a lot of confusion with the information because of how it was shared through the COVID press conferences. It just ended up turning into just great entertainment more than anything. You kind of had to do your own background research. So that most of the stuff that they were researching were for healthy people or people without some type of underlying condition. That side of those people within my family decided to get vaccinated because, like, well, they researched this, so we're comfortable. And then the other people weren't. So I think it was just kind of like teasing between everything that was out there because it was just so new. And the way that those press conferences were held, I think, lead us to like kind of where we are today with how people think about the vaccination stuff. So.
Absolutely. Thank you so much for sharing that. And I think you bring up a good point. Depending on a person's health status, that had a lot to do with how they felt about the vaccine. So yes, thank you. And Kim mentioned in the chat, I have several healthcare professional friends who believe the vaccine causes cancer or now HIV. They do not cite their references, yet they believe that this to be true. So it is very difficult. That's that's the first time I've heard something like that. But every time we do these trainings, I absolutely love it because we learn some different things and we hear some different things. Um, but it is interesting to hear the different perspectives, especially as it comes from different health professionals. Um, so that's a unique perspective as well. But it does also make you think because they're not citing their references. How factual is this? I've shared in previous trainings, I have a child that's of the TikTok generation that I like to call them. She doesn't believe it unless it's a dance associated with it or there's a short video. So my daughter was super convinced that somehow the vaccine would cause us to have superpowers or mutate into some form of X-Men. And I did just encourage her, hey, do your independent research. TikTok is a great resource, but also anyone can post a TikTok video with information that may be true or not. So it was definitely a learning experience for my child to explain to her, challenge these things, so do your own research. And do we know any X-Men yet? So we fortunately do not, or unfortunately do not know any X-Men. So that information may not have been true. So thank you. Does anyone else, is it Margarita? Do you want to share? Do you have anything to share to the conversation, or Dr. Custard?
Sure. In regards to friends sort of being more adverse to getting vaccinated, I was or am a doula, and so I was in sort of the first round of healthcare professionals that got vaccinated. And so some of my friends who were on the fence talked to me about it. And like I was in the Peace Corps, so I worked for the government, so I've been vaccinated for basically everything possible, and I'm fine. And so so I just sort of they were using anecdotal information to sort of be opposed, and I met them at the anecdotal information. I was like, look at me, I'm okay. Like, I think, and I wasn't accusatory about it. I listened to them in their concerns, and I just asked questions. I asked them more questions, to the point where some of them, months down the road were like, they told me that I was one of the only people that didn't get sort of more animated about it. Like, oh, you should do it. You should do it. Like, I just let people sort of come to their own. I'm not, in that instance or in that circumstance, I wasn't trying to convince anybody of anything. I was just trying to open conversation. So I feel like it worked, sort of.
Well, thank you so much for sharing that. And that is a very powerful tool. We don't want to be accusatory, because again, that just breaks down the communication between yourself and that friend or patient, client. But just asking some of those questions and having them come up to what works best for themselves. Because again, the patient is the expert on their situation, right? And as a provider, you're the expert on the medical side, but who knows better about the situation, their personal situation, than the person themselves. So thank you so much for that.
Sure.
Yes. And I heard lots of motivational interviewing pieces in that. So awesome. Okay. All right. So we do have time. We'll do a really quick case. What we'll do is I'll read the case, and then we'll just go through a couple quick questions, and then we'll be wrapped up. So this is the case of Eliza, and I'll go ahead and read it. Eliza, a 77-year-old woman, has been diagnosed with long-haul COVID after experiencing rapid heart rate, shortness of breath, and fatigue since she was hospitalized with COVID-19. She sits in her doctor's office listening to the instructions and going over the next 3 months' worth of treatment. The doctor assumes she must know what he is talking about, since she doesn't ask questions and tells her what she needs to do after a few instructions before her treatment begins. What the doctor doesn't know, because she's kept it a secret for as long as she can remember, is that Eliza does not know how to read because she dropped out of school when she was 8 to help with her family farm and never went back to learning. She has little medical background and barely knows anything about heart disease. He gives her pamphlets and written instructions that tell her everything she needs to know, but he doesn't tell her much about what the papers say. He says to let him know if she has any questions, and she responds with, "Okay, I will." Unfortunately, she can't read the material and is too embarrassed to admit she cannot read the information, which will lead to problems in continuing her health plan properly. So that's the case of Eliza. So, does anyone recognize any red flag behaviors?
Her not talking during the explanation of the information. So, and then the doctor didn't address it or, do the, I think you called it the talk back or
Teach back.
teach back. Yeah.
Right, so you can see in this instance how teach back could have revealed that, right? I really need to switch the slide. So how can her limited health literacy impact her diagnosis and her prognosis?
Well, since it sounds like the doctor didn't explain much, she might take the medications out of sync or not as timely, or if there's a time-sensitive medication, she won't know about it. So, but things like that.
Absolutely. Those are all good suggestions. And you kind of touched on this. How could the provider organization have been more health literate? So teach back was one of them. What other things could that doctor have done? What do you think? Go ahead, Javon.
I was some type of visual aid or something to explain exactly what's going on. Because I know when for me, when I dislocated my shoulder in football, the doctor had like a thing, because to me it didn't make sense because he said I was strong, but he's like, these little muscles are what's holding your shoulder into a socket. And then he showed me like where they were, and then he showed me the exercise that would actually like affect those areas. It was beneficial to me for my recovery for after that. So like things like that, something to touch on like all the senses of learning.
Yes, and props really do work so well. That's one of the things with Wash and Learn. We were doing the one prop with the drinks and all the sugar in each drink. I don't know if you've ever seen that, but props do work. Certainly using the handout more effectively, right? Too, he didn't show her anything on the handout. We don't know if it was even effective. So those are all great observations. Maya, were you going to say something?
Yeah, so Kim just popped in the chat that he could have talked to her a little bit more to establish trust so she would feel more comfortable opening up. And that is a great point, Kim. Thank you.
Mm-hmm. Absolutely. Okay. Back to Maya.
All right. So in summary, some of our key takeaways. Low health literacy is associated with lower health knowledge, poor medication adherence, increased use of ERs as a primary care, increased mortality rate, which all these things impact the quality of life for those with low health literacy. It is important to use, again, those universal precautions and don't assume that a person understands and just assume that all patients have low health literacy. Improving individual and community health literacy levels can reduce the vaccine hesitancy and increase COVID-19 vaccination rates. A final review. So again, it's recommended that all written health materials be written at a 5th and 6th grade level. Health literacy strategies can be used to increase the patient's understanding about their health conditions and also empower them to take an active role in their health. Clear communication, teach back, using linguistically and culturally appropriate materials, motivational interviewing, and combating misinformation also are some other health literacy strategies.
Awesome. Thank you, Maya. So here is our information. Again, you'll get the link to this video and the slides after. I will typically send them tomorrow. Before we go to this, there is an additional training from the CDC. Health Literacy for Public Health Professionals is another good overview if you're interested. And again, the resources to link to health literacy resources. So let's go back to this. If you could please first of all, thank you for participating in our health literacy training. Does anyone have any final comments, questions, concerns, anything they'd like to share?
I just want to apologize for being late.
It's
I
okay.
had a meeting run over. Will we get the recording of the training or?
Yes.
Yes, okay, great. Thank you.
Yes, and I do apologize to everyone. Today was just a weird day. My foot was in my mouth many times, and that's okay. So I'm going to go ahead and stop the recording. Oh, let me go back.